It's the 2nd of April, 2021. This is the RheumNow podcast. Hi, I'm Dr. Jack Cush, executive editor of RheumNow.com. HSP, ESRD, UPA, SAE. If you're a rheumatologist, you know what I'm talking about. If you're not, you're probably not listening to the right podcast. Let's begin with a report of rheumatology's favorite drug, methotrexate. Which should you use? Should you use sub-Q? Should you use oral? I've always used oral, and then I occasionally use sub-Q. I know the data about the better absorption, 100% delivery, more toxicity with parenteral injectable sub-Q methotrexate. But, you know, we use a lot of oral, and it works just fine in most people. I was shocked to find out 10 years ago, more than that most of my pediatric rheumatology colleagues in Dallas and throughout the country prefer to give their kids with JIA sub-Q methotrexate. Are they right? You know, and I don't know that that's really been well studied. Well, here's a study that actually did look at a fairly large cohort of 640 RA patients who either started sub-Q or oral methotrexate. And again, it was, I believe, the design of the trial was to prove which one is better. So this is a randomized active control, if you will, study to look at if it's superior or non-inferior when you use oral versus sub-Q. So that's exactly what they did. This study, I think, had an endpoint of 24 weeks or something along those lines. And bottom line, in the end, there was no difference in the amount of disease activity or disease control with either sub-Q or oral, which meant that it was basically non-inferior. If anything, maybe the oral methotrexate had fewer adverse events overall, 42% versus 52%, and that was significant. But a lot of that, as you know, with methotrexate is nuisance side effects. So here's what I do. I don't use really parenteral unless a patient can't take oral. But for the most part, I use oral once a day up to 15 milligrams. When I'm at 15 milligrams or higher, I do split dose oral. So I will then use 3 pills twice a day on Friday. That'll be 6 pills for 15 milligrams. And I'm going to get better absorption when I do that. Same things if it's 20 milligrams. It's 4 pills twice a day on Friday. And I'm going to get basically 90% absorption on that. Again, once you get at 15 milligrams or higher, methotrexate and how it works and how much absorbed is sort of a roll of the dice. So not leaving it up to luck, the UK has now approved a new therapy for Still's disease, whether it's kids with systemic JIA or adults who have adult onset Still's disease. NICE, or the regulatory agency in the UK, has just approved anakinra for first-line biologic use in kids with systemic JIA or adults with adult onset Still's disease. But, big but, they must have failed a DMARD prior to getting the biologic. You know, that seems like a right move, a good cost efficiency move. But you know what? If someone has systemic features of either Still's disease in kids or adults, you know, methotrexate, Plaquenil, azathioprine, cyclosporin, they don't work. You know, when you have the systemic features, high fevers, the rashes, the pleuritis, hepatosplenomegaly, crazy looking labs, white counts of 25,000, and acute phase reactants off the chart, that needs steroids and an IL-1 or an IL-6 inhibitor. So while I applaud them for making this move, I think that they should have had a proviso on there for how to treat systemic Still's patients versus those who have chronic articular Still's, in which case you can use any DMARD you want, any biologic you want. Basically, at that point, you're treating RA. Jeff Sparks and colleagues published a nice study that I actually read prior to publishing on RheumNow, and that's a nurse's health study that looks at the frequency of COPD in RA patients, and I think it's an interesting study. So they looked at 283 pre-RA patients, meaning that from their many thousands of patients, they found 283 patients who were going to ultimately go on to develop RA and follow them for 10 years prior to RA. And they had about 3-to-1 matched controls. 20% of the pre-RA patients were ACPA positive. Turns out that ACPA positivity was associated with an increased risk of both COPD, a 3-fold increased risk, and also asthma, and to a much lesser extent, but mainly COPD. There is this curious interplay between inflammatory lung disease and preclinical RA and RA itself. So is that part and parcel of disease that add to the pathogenesis of disease? I think it does. And we do know that both having ACPA and having COPD makes your patients with RA maybe a little bit worse, makes them more likely to have pneumonia and pulmonary complications. So there is this association with COPD and restrictive airway disease in patients with RA, and it's possible that ACPA positivity is at the root of that. Airway inflammatory disease may be a forerunner to actually developing articular rheumatoid arthritis, especially in ACPA positive individuals. So speaking of lung, a nice study from Spain looked at a collective experience from multiple centers on their use of abatacept in patients with RA and interstitial lung disease. So they pooled their patients, 363 patients, and they were either treated with abatacept alone or abatacept in combination with either methotrexate or another drug other than methotrexate, so another DMARD, if you will. And it turns out that they all did well with regard to their clinical improvement as measured by disease activity score, as measured by their lung function with FVC, DLCOs, and even chest CTs. Those were stabilized in patients who were started on abatacept. It didn't say why they were started on abatacept, but they were on abatacept. They had ILD and RA. The only difference here was that there was a steroid-sparing effect seen when you use the combination. That the patients who were on abatacept alone, without a DMARD, without methotrexate, were more likely to be on higher doses of steroids going forward. And that could have been steroids for their lung or steroids for their joints. Point is that if you're going to go so far as to use abatacept, you probably should be using it in combination, whether it's for the control of RA or to hopefully affect the outcomes of RA-ILD, a difficult to treat complication of RA. An interesting study from the journal Rheumatology looks at a retrospective experience from Australia, the Great Down Under, with 267 adult patients with Henoch-Schönlein purpura, henceforth known as IgA vasculitis. Overall, these patients had a lot of GI involvement, as you would imagine, some articular involvement, and renal disease. But what I found surprising about this particular large cohort report was that these patients have a significantly higher rate of comorbidity, and it was like almost double that what you see in patients who did not have this. So who's their control here? Let me think about it a second. But anyway, higher comorbidity scores, that's a Charleston Comorbidity Index, 2.6 versus 1.5. They had a higher risk of serious infections, an overall risk that was 8 times higher if you had a diagnosis of HSP. You slice and dice it with other provisos, it's still higher at 2-fold higher, but as high as 8-fold higher. And they also had a higher risk of death, a 2-fold higher risk of death when compared to the general population. So having HSP is not necessarily a benign condition in adults. I found this nice abstract, albeit 6 months late, from the American Society of Nephrology that looked at an open-label collective real-world experience of end-stage renal disease patients who are on dialysis, most of which, I think 80% of which, were on hemodialysis, 136 of them, and they needed to be treated with IV pegloticase. There was no real downside here. More than 2/3 of the cases, the pegloticase was prescribed by rheumatologists. These were mostly males with an average age of 57 years, and interestingly, they received the pegloticase for up to a median, actually not up to, but a median of 13 infusions, without any particular mention of bad outcomes here. So this is a difficult population to manage. End-stage renal patients on dialysis, gout can be severe, gout can be really bad, and they may or may not be on other drugs that interfere with your usual gout therapy. In this case, the use of pegloticase seems to have made sense. I can't say I've done this myself, but I would do this in the future. Meta-analysis of 32 patients looked at the risk of stroke in your patients who have inflammatory or autoimmune disease. Specifically, this cohort looked at a large number of patients who either had RA or PsA, or I want to say the other inflammatory arthritis in here was gout. It was, and ankylosing spondylitis for that matter. Overall, patients with inflammatory arthritis have a 1.5-fold higher risk, or actually a 45% higher risk of either ischemic stroke or hemorrhagic stroke. And this was true for RA, 38% higher risk, ankylosing spondylitis, 49% higher risk, psoriatic arthritis, 33% higher risk, and gout, 40% higher risk. Interestingly, most of the risk of stroke in patients with inflammatory arthritis was higher in patients who are younger than age 45, not the elderly. So that's the population you may want to be on the lookout for. SAE, anti-SAE antibodies, not serious adverse event. What is SAE antibodies, and why are we talking about that in the context of dermatomyositis? Lisa Christopher Stein and colleagues are running a national, basically, registry or database of suspected myositis patients. In doing analysis of over 2,000 suspected myositis patients, they found that 1% of their population, nearly 1%, tested positive for SAE antibodies. That stands for SUMO activating enzyme. SUMO. What does SUMO stand for? Small ubiquitin-like modifier activating enzyme. That's a mouthful. Why do I need to know about this? I'm a rheumatologist. I don't know anything about this. Should I know about this? Well, it is 1% of all suspected myositis patients. It could be tested for. These patients present first with rash, then later with myositis, often with a lot of extra muscular involvement. But like some of the other syndromes we've seen, there is an increased risk, a small increased risk for cancer in this subset. So that's probably the cancer hook here might be the main reason to know about SAE antibodies in dermatomyositis. Our last report has to do with upadacitinib. New England Journal reported this week about upadacitinib's clinical trial, a very large clinical trial, 1,700 patients with active psoriatic arthritis who were randomized to receive one of two doses of upadacitinib, UPA 15, UPA 30, versus standard dose of adalimumab, which is 40 milligrams every other week, versus placebo. Their primary endpoint was at week 12, and yes, UPA outperformed placebo significantly. 15 milligrams UPA had an ACR20 of 71%. 30 milligrams UPA had an ACR20 of 78%. Placebo response rate was 36%. Wait, there was another group, that was adalimumab, that had an ACR20 response rate of 65%. Thus, UPA at any dose is more significant than placebo. UPA 15 milligrams is roughly equal to adalimumab 40 milligrams every other day. That's 71% versus 65%. But the dose that's not approved for UPA, 30 milligrams, was superior to adalimumab. That would be 78.5% versus 65%. There was a fair amount of some hepatic enzyme elevations in this trial, more than you might have wanted to see, both for the 30 and 15 milligram group. Again, you do need to check for LFTs and CBCs quarterly in patients, I think, that are on JAK inhibitors, not just UPA, but all JAK inhibitors. I do twice a year. I'll check for lipids and or CPK, because you have this low-level CPK-emia in some patients. Haven't yet seen a really good case of myositis associated with JAK inhibitors, but again, we're seeing an expanded use of JAK inhibitors now in psoriatic arthritis. Tofacitinib is approved. Upadacitinib is up for approval in the next quarter by the FDA. Watch for that information. We're going to end with two cases from Backtalk where you can send a question to me in RheumNow or present a little case. Dr. Mark Cruciani sends in a case about or concern about women who he sees in consultation who are ANA positive and have complaints of alopecia. ANAs can be low positive, can be high positive, and the question is, what does he do with it? Should he send them all to dermatology, etc.? I think it's important to have a discussion about alopecia with your patients. Many women will have hair loss. Is it pathologic? Is it associated with lupus? Lupus can have just general hair loss, can have patchy hair loss, can have scarring alopecia, which is what goes along with DLE, discoid lupus, or non-scarring alopecia, which is a criterion for the new ACR criteria. As you know, the new ACR criteria require you to have an ANA and then a bunch of features for which you get points, and you need to have 10 points. So Mark, your patient who is ANA positive with alopecia, she gets 2 points for non-scarring alopecia. She's 8 more points away from having a diagnosis of lupus, and this is about what we really see. Often these patients do not have lupus, and it's your job to look for the other 8 points, other features of lupus, to say whether the patient has SLE or not. And then if the patient is bothered by their hair loss, send them to a dermatologist to see if this is telogen effluvium or some other diagnoses that I know nothing about that could cause alopecia. My bottom line, I learned from some very smart rheumatologists, dermatologists, Rick Sonheimer and others, say that when patients have spontaneous hair loss, meaning they wake up in the morning and there's hair on the pillow, enough that you got to brush it off, that's pathologic. Hair in the shower, hair on the brush, hair on your clothes, unless I can see big patches of hair loss, I don't really care. It's not going to be pathologic. There are 2 things that get my attention, which I'm going to do something about right quick, as we say in Texas. 1, spontaneous hair loss. It's on the pillow every morning. Again, I don't care about brush, don't care about the shower, don't care about your coat. Or 2, when the patient says, I thought I had a problem, but my hairdresser said, what's going on with your hair? I'll listen to that, because that's someone who usually knows that person's head of hair intimately and can spot either patches of loss or significant loss that needs medical attention. So that's my approach to hair loss and ANA positivity. We got another case from Dr. Hussein Babani. Let's listen to what Hussein has to say.
Hi, Dr. Cush. My name is Hussein. I'm a rheumatologist from Kuwait. I have a lady who presented to me with bony prominence over the sternoclavicular joint. She has minimal pain. She denies any history of a skin rash, acne, or psoriasis. We did MRI of the sternoclavicular joint, which showed erosions with synovitis, and the radiologist suggested SAFU syndrome. As I said, she has minimal symptoms at this point, but the prominence is annoying her. So at this point, would you recommend starting DMARDs or just to start with a local steroid injection? Thank you.
Hussein, thanks for that case. Very interesting. The real issue is here, what's the differential diagnosis of sternoclavicular arthritis, especially with bony enlargement? This patient does not have a diagnosis. He's wondering if it means the patient has the SAFO syndrome. In my experience, patients with isolated sternoclavicular arthritis, when it's new and acute, is septic, and infectious otherwise. This is common in IV drug abusers. It's common with systemic staph infections. But also you get weird bugs there, including Pseudomonas, especially in IV drug abusers, but occasionally mycobacterial infections, occasionally Brucella. Brucellas are really, especially in your country, I'm sure you have brucellosis. This patient should have an antigen test for Brucella. And, think about infectious. So this patient sounds like it's chronic because it's enlarged, but there's no other symptoms. So you have to think of indolent infection. I would test for TB. I would check for Brucella. I might aspirate the joint if possible. I think imaging is really important. You did an image. If you want to look for erosions to say this is an erosive arthritis as opposed to a degenerative process, CT scan is probably a little bit better than MRI in assessing SC arthritis, but both should look for whether or not there's erosions there, because maybe in that situation injection and or systemic therapy would be appropriate. But again, she doesn't have a systemic arthropathy. I don't know that I could give her a systemic therapy for a local problem. My workup would probably be to aspirate the joint, but I want to know why your radiologist says that this is the SAFO syndrome. SAFO stands for synovitis, acne, pustulosis, osteitis, and hyperostosis. This is an inflammatory condition that affects amphiarthroses, sliding joints, most notably the sternoclavicular joint, the manubriosternal joint, the AC joint, sometimes costochondral joints, sliding joints, and you get an inflammatory synovitis there. This has a remote relationship, and I'm not even sure it really is pathogenically aligned with spondyloarthritis, but they're often talked about together. Most patients who have SAPHO do not have spondyloarthritis. Actually, in the differential diagnosis of an isolated sternoclavicular joint, we said infection, we said SAPHO. There are others. Rarely could this be something like sarcoidosis or reactive arthritis or psoriatic arthritis. Even rheumatoid has presented here. But again, there's other evidence of other joints involved to give you those other diagnoses. So if there's osteitis, then that's why your radiologist would have suggested SAPHO. If it's just osteitis, I still think you may need to do an aspiration there, or maybe even a bone biopsy there if that's really bothering the patient. I would seldom send these patients to surgery. I don't think you're going to get any remodeling or significant improvement. She's having no pain. Injecting a steroid there is not going to help what is bony and large. She may need a bone biopsy. But if there's fluid in there, then I would aspirate, culture it, think about the infections we talked about. But based on what you said, I'm not really inclined to want to give her a DMARD. I wish I could help you more, but such cases are often difficult. That's it for this week on RheumNow. Starting in the next 2 weeks, you're going to start seeing a lot of RheumNow live content, including my lecture on RA and pneumonia, which goes back to some of these pulmonary reports we heard in today's talk. Tune in for more next week on the podcast.